Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and welcome to first episode of 2026. It's been a while, so this year we have New Year resolution to continue recording episode at least one per month. Thanks for your commitment, Maddie.
Yeah, we're sorry about the last year. It's we weren't as regular with the episodes as we would have liked to be, but starting off on a new foot in 2026. So we're going to really try to do the one episode per month.
That's right. So let's dive into today's snippet. Can you please classify the mechanism of actions of anticonvulsant drugs and outline the pharmacology of gabapentin?
Sure. So in terms of anticonvulsant drugs, there are several sort of mechanisms. The different mechanisms are ones that enhance GABA transmission, ones that inhibit excitatory transmission, and ones that act on ion channels, as well as an other mechanism category. In terms of those that enhance GABA transmission, we know that GABA is one of the main inhibitory neurotransmitters. So there are different ways that the GABA transmission is enhanced. One way is by the receptor, so the GABA A receptor, and there are drugs such as benzos or barbiturates that cause positive allosteric modulation of this receptor, and therefore it causes some postsynaptic inhibition. Other ways that GABA transmission can be enhanced is by inhibition of GABA reuptake. So this is drugs like tiagabine, which I don't think we use very commonly at all, or those that inhibit GABA metabolism. So GABA is usually metabolized to succinate by mitochondrial enzyme GABA transaminase or GABA-T. So there are drugs such as vigabatrin or sodium valproate that inhibit GABA-T, so mean that functionally there's more GABA available. And then finally, there are drugs that can increase GABA production by increasing glutamate decarboxylase or GAD. So GAD is an enzyme which catalyzes the conversion of glutamate into GABA. So drugs that work through this mechanism are sodium valproate. Coming to the next big category of anticonvulsants are those that inhibit excitatory transmission. So this is generally by inactivating glutamate receptors. So glutamate being one of the most widespread excitatory transmission, any inactivation of this will reduce excitatory neurotransmission. And examples of these are things like NMDA antagonists such as ketamine or AMPA antagonists such as perampanel. And then finally, there are ones that act on sodium ion channels. Sodium channel blockade is the most common type of anticonvulsant. So these include a lot of the drugs such as phenytoin, carbamazepine, lamotrigine, lacosamide, or topiramate. There are also drugs that cause calcium channel blockade, which reduces the influx of calcium, and this decreases the neuronal excitability. And these are drugs such as ethosuximide, which block T-type calcium channels, or things like pregabalin and gabapentin and topiramate to an extent, which block the auxiliary alpha-2 delta-1 subunit of calcium channels. And then there are potassium channel activators. So these open potassium channels which release potassium, causing hyperpolarization of the cells. And therefore, their cells are less able to reach the threshold for generation of an action potential. And then it stabilizes the neuron membrane and that reduces firing. So this is drugs such as reticabine. And finally, the only real one is levetiracetam or Keppra, which is SV2A binder. And so this binds to synaptic vesicle protein SV2A, and that alters vesicle fusion and changes synaptic transmission, but the full mechanism of action hasn't been fully elucidated. And then coming next to gabapentin specifically. So gabapentin is an analog of GABA, which, as we've spoken about, is an inhibitory neurotransmitter. We can divide the pharmacology into pharmaceutics, pharmacodynamics, and pharmacokinetics. So from a pharmaceutics perspective, gabapentin is available in oral tablets or capsules, and these of strengths that range from 100 to 800 milligrams, although usually people are in a range of about 300 to 400 milligrams TDS for a dose. From a pharmacodynamic perspective, the exact mechanism of action has again not been fully clarified, but is thought to be due to gabapentin's high affinity for the alpha-2 delta-1 subunit of high threshold voltage-dependent calcium channels. And this causes a reduction in calcium influx, which reduces the excitatory neurotransmitter release of things such as glutamate, substance P, and noradrenaline. But interestingly, even though gabapentin is meant to be an analog of GABA, it has no effect on GABA receptors. Other thoughts about how it might work include increased GABA synthesis and concentrations within the brain, but this hasn't been clarified fully. It's mainly used in the treatment of partial seizures, including secondarily generalized tonic-clonic seizures as an adjunct therapy, and in the treatment of neuropathic pain, which I think is one of the major reasons I've seen it being started in the ICU. And from an adverse effect point of view, the most frequently reported a sort of extension of its activity, causing things like somnolence and fatigue, but also nystagmus, nausea, dizziness, and ataxia. And it does have a rare association with skin life-threatening conditions such as Stevens-Johnson syndrome and TENS. From a pharmacokinetics perspective, we can divide it into the absorption, distribution, metabolism, and elimination. So from an absorption perspective, gabapentin is absorbed in the intestine by the LAT1 transport. And this is a saturatable process. So the oral bioavailability is inversely proportional to the administered dose. But over the recommended dose range, the bioavailability difference is not that significant, and it has an average bioavailability of 60%. Although for very high doses, at the highest end of recommended dose range, the bioavailability decrease. Things like having food or liquid beforehand has no impact on the absorption of gabapentin. From a distribution perspective, the volume of distribution is approximately 58 litres, and it's poorly protein bound, so less than 3%. It undergoes no significant metabolism, and the majority of the drug is excreted unchanged in the urine with a half-life of 5 to 7 hours in patients with normal renal function. But the clearance is directly proportional to creatinine clearance, so we do need to dose reduce in patients with renal impairment. Because of these characteristics, it also can be removed by hemodialysis if required in toxicology or overdose situations.
Thanks, Maddie. That's the end of today's snippet. We'll be back with another snippet in a month's time. Till then, goodbye and have a nice time.
Thanks for listening, and see you next time.